symptoms, signs of Parkinsonism. One of you is Lokesh or exam going, anybody is there? Or one of those who are here, Anish or Prasunna. Parkinsonism. So,
hypokinesia, tremors, rigidity, and postural instability.
good. That is a way we must say, actually. The points have to be clear in the clinical exam, you know. So just without waiting one full sentence, just 4 things. Okay. Now, what are the Parkinsonism plus syndromes, Anish? What are Parkinsonism plus syndromes?
Progressive supranuclear palsy.
We should not wait.
Lewy body
Continuously, you must talk like 1, 2, 3 type of thing. Okay.
Lewy body dementia, corticobasal degeneration.
Corticobasal degeneration. Corticobasal degeneration. Okay. Then what else?
MSA, multi-system atrophy.
MSA, multi-system atrophy. So in the order, I would say, first say PSP, then say MSAP, then say then the other disorders are rather rare. So first 2 are more common among the Parkinsonism plus. Is that okay? So what are they? Parkinsonism plus PSP, MSAP, corticobasal degeneration, Lewy body dementia. Pardon? Anything else?
Alzheimer's, Pick's disease.
No, that should be coming under dementia. Parkinson's plus may have dementia as an extra. Parkinson's, Alzheimer's and all will not have Parkinsonism symptoms, signs. So do not mention that. So I'll say it again in the exam. They don't expect you too many details, but you should be able to list few conditions. What are they? I'll say it again. PSP, MSAP, multi-system atrophy P, and then the other are corticobasal degeneration, striatonigral degeneration as part of MSA will come, Lewy body dementia. All dementias don't mention because all dementias don't have Parkinsonism as a component. Is that clear? Now we'll look at what you have to do is under each of these you must write 2 points if possible. PSP, for example, the first thing is the gaze, vertical gaze abnormality. Second is saccadic gaze will be, so eye signs are important. 3 eye signs are there. Vertical gaze abnormality number 1. Saccadic movements are jerky, called cogwheel saccadic movements. Number 3.
Lidapraxia.
What is the number 3?
Lidapraxia.
No. In the eye, I didn't get here what Bhakya said. In the eye, there are 3 signs. The lid retraction. So what will happen to the eye? Eye will become as if you are looking with a surprise. The surprise look in the face. So eyelid retraction. Those 3 eye signs. Then extra dysphagia, dysarthria, pseudo-bulbar palsy. That will be enough actually, if you can remember that for PSP. One more thing to remember is in MRI, midbrain degeneration. What are the radiological signs you get?
Hummingbird sign on mid-sagittal sections.
Yes, yes. Any other? Any mouse
Yeah.
sign?
Mickey Mouse ear.
Mouse ear appearance or Mickey Mouse. Okay? So that would be enough to say PSP. If you say vertical gaze, so in a Parkinsonism, what you do is look at the eye, three things. Is there a vertical gaze problem upward on command, not on showing an object? Ask them to look up, look down, look to the side for saccadic movement, look whether the eyelid is retracted. If there is specs, remove it and then see whether the eye is in a surprise, wide-eyed appearance. Okay? Then other extras are dysarthria, dysphagia, that is. Okay. Now, MSP, what are the three disorders which come under MSP? Okay.
Parkinsonism features and autonomic disturbances. MSP patients will have autonomic dysfunctions first before development of Parkinsonism features.
Now, what you
they
can
will
say
present
is
with
that, yeah, I will tell you the answer, how to say it. There are two ways of saying. One is MSA C, that means multi-system atrophy with lot of cerebellar signs and Parkinson's signs. There will be pyramidal signs, eye signs, okay? The other is MSA P, lot more of Parkinsonism. And the third is MSA A, that is autonomic disorders, okay? So using the letters, you can say MSA C, cerebellum, MSA P, Parkinsonism, in addition to other systems. Other systems are pyramidal system, eyes, many other systems in the neurological system can be involved. Is that MS? A is actually Shy-Drager syndrome. Another grouping under MSA is striatonigral degeneration, olivo-pontocerebellar degeneration, and Shy-Drager syndrome. Okay, that's a older three. Maybe easier if you say MSA-CAP. A is Shy-Drager, marked autonomic. That is Shy-Drager. P is marked Parkinsonism plus other extra signs. There may be pyramidal signs, there may be eye signs, etc. Striatonigral will be mainly Parkinsonism, but other systems also may be involved. Is that clear? Under MSA, three older classification and three newer classification. Is that clear? What is special about MSA compared to Parkinson's disease? One is tremor is rare and symmetrical involvement, whereas Parkinson's disease always starting asymmetrically. Even in the course of the disease, it remains asymmetrical, one side more than the other. Okay. Hot cross bun appearance in MSA-C due to degeneration of pontocerebellar fibers. Levy body is a nuclear inclusion body. What is the main thing? Dementia is very prominent. Whereas ordinary Parkinson's disease, dementia is not common. Some few less than 10% will have some memory defect. If marked dementia, think of either Alzheimer's or Levy body disease. One characteristic of Levy body disease is episodic behavior change, almost look like a mental patient, and hallucinations. So I'll say it again, Levy body, just write the points. Dementia, Parkinsonism, behavior, episodic abnormality, behavior, hallucination. 4 points under Levy. What is Segawa syndrome? What is Segawa syndrome? Anybody? Okay. Segawa syndrome is an important syndrome because I tell you the reason why. If you diagnose it and you give a dose of L-DOPA, 10 milligram per kilogram, few doses, they become all right. You will never have a Parkinsonism like that. You can never make a Parkinsonism patient be sort of cured in a sense. I'll just be back. One. You can note it. It is juvenile, each word below the other. That's the best way to remember these points. Juvenile, dystonic, next Parkinsonism, hereditary, DOPA responsive. So in other words, practically what is important? Exam, they won't show this patient. They may just say, they may just ask because of this. If you find a young person, usually within even very young age, 4 to 8 years, they come unusually with Parkinsonism-like features, with dystonia, with a family history. Always give them a trial of L-DOPA, marked relief from L-DOPA in a patient like this. Can you, none of you, read out the points under Segawa, which I mentioned, just to see whether you got it fully?
Juvenile dystonic Parkinsonism with family history and DOPA responsive.
That's it. That is enough. If you say that in one sentence is enough. Hereditary, okay, juvenile, dystonic, Parkinsonism, which has a dramatic response to L-DOPA. That is it. One sentence, all the 5 points are there. Is that clear? So we will stop here. How does it come in our practice or the exam? Exam, one of the exam in the Trivandrum Center, as I mentioned, they asked a lot about it. Few people only will ask too many things. But if you have a list of 5 conditions which we said, one after other, you just quickly say. And PSP, don't forget the gaze, MSA, multi-system plus the Parkinson, MSA-P, Levy body disease. We have already said they have the hallucinations, behavior, dementia. And Segawa is more of a, sometimes they may ask you, corticobasal name itself, cortex and base, is not only substantia nigra, basal. The cortex means what will happen? Pyramidal signs. They will have dementia later. So name itself will give you corticobasal. Striatonigral means that's part of MSA. Okay? Is that clear? Some clarity in what is Parkinsonism plus? What are they? Uh, if any of one of you can tell without looking back here, without looking into your book, what are the Parkinsonism plus syndromes?
Progressive supranuclear palsy, multisystem atrophy, Lewy body dementia, corticobasal degeneration.
MSA-P you have to say. MSA, multisystem atrophy, P. Okay? Next one.
Lewy body dementia.
Yeah, that's a more rare. It comes a little, you can, striatonigral degeneration. Part of MSA it comes, okay? And then you can, if you say MSAP, that will be enough. Corticobasal degeneration and
Lewy body dementia.
Lewy body dementia. Under MSA, you have to have two diseases can present with Parkinsonism. So you have to say MSAP and MSA-A with shy dragger. That name you have to say, shy dragger syndrome. Okay. The other is striatonigral degeneration. Those two will present with Parkinsonism under MSA. There are two things under MSA. PSP, MSA, two things, corticobasal, Lewy body dementia. Is that clear? It will just a name. And each one there is something special that we said, Lewy body, dementia and hallucinations and behavior change. Corticobasal, pyramidal signs and extrapyramidal signs. And other things we already discussed. Now we will discuss one other question. They will keep is a patient with a large spleen. What is called massive splenomegaly. That you see in the wards also. A quick way of differentiating the diagnosis. First of all, can you give a list of conditions with massive splenomegaly? Splenomegaly, massive, mild, moderate, massive. Mild, for example, infective endocarditis. You can have a small spleen, typhoid, enteric fever, small spleen. Moderate is usually conditions you can get in malaria. Massive also you can get in malaria, okay? And massive is the big spleen, reaching up to the umbilicus, usually. Now, if you have a patient, what are the causes of massive splenomegaly? That's the first thing. It's not neurology, but then I thought I'll cover some of these exam type of things. Can you give me a list of massive splenomegaly causes? Can you tell?
Early stages of sickle cell. Early stages of sickle cell
No,
anemia.
actually, don't say sickle cell because in part of the sickle cell, as the disease progresses, it gets into autosplenectomy. No? So don't mention, what is the rule in Prasanna? What's the rule of answering a question like this? Every question in the exam and in the wards, when you present, discuss. What's the rule?
Most common causes we have to tell first.
First, yeah, that is the most common. So the least common should find only. So sickle cell, not even mention it, because that's not a cause of a massive splenomegaly in the chronic stage. Okay, can you give me a list, Prasanna? You can try a list, 5 causes in one breath. course, you can take one more breath in between.
Sir, I remember only the rarest cause, hairy cell leukemia.
Yeah, that is a problem
Chronic myeloid.
for all of us. The rare things will come first. So one of the examiners get very upset. That is why, suppose in a question like if you say hairy cell leukemia, they will be very, very upset. So that's why I'm stressing this point. Every time, practice it now itself. When the consultant asks you a question, tell them most. Okay, I will tell you a list of, you can write it down. CML, chronic malaria, Kala Azar. You can write down the list one below the other, because give a little space so that for each one there are some points you can. Then little more rare things. Lymphoma, more usually is a moderate size but can become. Portal hypertension can have moderate or massive. Myelofibrosis, hairy cell leukemia, tropical splenomegaly syndrome. Okay, do you get about 7? Now you can somebody tell it without looking, like without looking into the book from memory? Can you say, Anish? You want to try? Check your
Chronic myeloid leukemia, chronic malaria, then Kala Azar, then myelofibrosis, then
yes,
portal hypertension,
hypertension, lymphoma.
lymphoma, and
Then now you
splenomegaly
can look at the list and lymphoma and
and tropical splenomegaly syndrome.
yes. One more I would like to add: polycythemia
Hairy cell
leukemia. Above the hairy cell leukemia, write more common: polycythemia vera rubra. Polycythemia vera rubra. Okay, those are old ways of saying, but that's easy. Then you will remember it actually. Okay, you have so many causes. Now, you may have a patient, only finding is spleen. How will you discuss the differential diagnosis? Okay, Prasanna? Discuss CML. How will you diagnose CML clinically? We are not thinking about. Only thing, there will be a big spleen to the patient, nothing else.
History of frequent infections due to neutropenia, bleeding manifestations due to thrombocytopenia.
No, the answer is like this. Just listen to me. The CML has got 3 phases: chronic phase, accelerated phase, and blast crisis phase. Okay? Okay. Chronic phase, accelerated phase, and blast crisis. And the signs and symptoms will vary according to the phase. That is how you have to have the idea. When you answer, you say that CML, in chronic phase of CML, patients may have only a massive splenomegaly and will have complaints like heaviness in the abdomen due to the massive spleen and easy fatigability, nothing else. What is accelerated and blast crisis phase? Can you tell me, Bhagya? Do you know what is accelerated phase, blast crisis phase? So in the discussion, you should not straight away start saying unless you mention the phase, because symptoms, signs will vary according to the phase. Okay, accelerated. Anish, do you know at this accelerated phase of CML? Have you all seen a CML patient? Okay. Okay. What is accelerated phase, Anish?
Blast is more than 20.
A little louder, yeah, speaker.
The blast is more than 20%.
No, clinical. We are talking about clinical. It's an exam setting or the ward setting. Clinically, you are diagnosed. Now, what is the meaning of the word accelerating means? The chronic phase is now changed into an acceleration of the leukemic process, ending in the final blast crisis. So the stage between chronic phase transitioning into the blast crisis phase is accelerated. Means what are the clinical signs will be? The spleen, which was slowly growing, is now rapidly growing. The patient will say, I had the swelling for 3 years, but last 6 months it has become very big rapidly. Then they start developing anemia, thrombocytopenia, not severe, which was not there. In classical CML chronic phase, the platelets are also normal or increased, no anemia, no lymphadenopathy, no fever, only fatigability and this heaviness of the mass. Okay, is that clear? Okay. Prasanna, what is the blast crisis phase? What will be the clinical findings?
I don't know, sir.
Don't know? Okay, Bhakya, you want to try? So your theory reading, according to the, after the theory, when you come into the practical, which I am now taking more in the practical, but I am combining some theory also here. The Bhakya knows?
But sir, only peripheral findings only I would know. More than 10% of
Peripheral. Okay, I will tell you the answer. See, blast crisis, you will see that this patient who was going along for 3 to 5 years with a mass in the abdomen, usually 3 to 5 years, will transition to a rapid enlargement, start developing anemia, start developing easy bruising. Then in another few weeks or month or 1 or 2 months, become febrile, lymphadenopathy appears, severe anemia comes, thrombocytopenia comes, gum bleeding, easy bruisability. The patient looks very sick, like an acute leukemia. This leukemia can be either acute myeloid or acute lymphoid. ALL or AML it can become. But you better say AML because it's chronic, myeloid leukemia. Most likely it will go, commonly it go into AML. Is that clear? I have tried a little on CML also, which you can read. After the theory, of course, you may have a theory question of a massive, discuss differential diagnosis of a massive splenomegaly can be, but usually it comes in the clinical, but it can be. Is that clear now when you are asked a question? It's a catch question. CML, what are the clinical signs? So the examiner can immediately make out, are you in a PG mode? Are you as a postgraduate level you are discussing? The undergraduate level, what you say is fine. Yeah, it is. But actually, if you say there is anemia, thrombocyte, it is incorrect because, as I said, it depends on the phase. So how will I say? In an exam patient with just spleen, nothing else, I consider the possibility of a chronic phase of CML. That is the answer. Okay? So the examiner notes the word chronic. That means this person knows a little more about CML and it's okay. Then they may ask, what do you mean? What are the other phases? You can tell what I already said. Is that clear? Okay. Now, next condition is chronic malaria. Can you discuss chronic malaria? Differential. Prasanna? We don't have much here because more in middle and north India, middle India like Orissa. I've seen those Kalasar, those things are mainly in northern countries. Bihar is very common. And so there it is an exam case. Here also we must discuss because it is prevalent in India and travel now, because it. Okay, now back to chronic malaria. What is how will you
Fever.
discuss? Pardon?
Pyrexia, fever, prolonged fever.
That's not very good answer because fever in malaria, what is the characteristic?
Depending on the organism, tertian or quartan fever.
No, the first thing is whatever the organism is fever with chills or rigor, isn't it? Fever with chills. Episodes of fever with chills. And it will come alternate days, once in a third day, etc. Okay, that is the quotidian and other thing. Is that clear? You have to say fever and chills. What are the clinical situations? Somebody comes with fever and shaking chill. Chill is two types of chill. The patient feels cold and covers. But to say rigor or chills, you must see the shaking. That only you can be very sure. And shaking chills. Malaria, because we don't see it here. If you just see them, you can make a diagnosis of malaria. And after some time, there are 3 stages in the fever. Anish? Malarial fever. Okay, I'm checking. I thought you were reading the theory also, because you don't see malaria here. Anish, you want to make a guess? Or? Okay, I'll tell you the answer. Okay, the cold stage, the hot stage, the wet stage. Okay, what is it? Cold stage. Patient says, I am feeling cold. He wants a blanket. One is given, not enough, to give me 2 more. That's no fever. Then hot stage, fever starts. Which comes first? Chills. Then fever. What is the wet stage? Diaphoresis. Sweating. This is a classical. So the answer for differential for fever in malaria splenomegaly is I will ask for history of fever and chills intermittent fever, chills, and residing in a malarial prone area like Orissa or Bihar and other, or with a travel history to these areas. Otherwise, there is no other symptom. No signs, it will be only a big. What is tropical splenomegaly syndrome? Bhakya. Whatever you know, you must.
Disease will be
Whatever
presentation
you know,
of disease. Presentation of disease will be particular to some endemic area, and they will have eosinophils in the peripheral blood smear.
No. I'll tell you the answer. Tropical splenomegaly is a syndrome characterized by massive splenomegaly in patients resident in endemic malarial areas. The patient need not have history of typical malaria. It is not eosinophils, don't mention. It is actually lymphocytic. That is in the spleen. If you do the biopsy, you find a lymphocytic infiltrate. It is due to an immune response to exposure to malarial antigen. So I will tell you in one sentence. You can write the point. Tropical splenomegaly is a syndrome presenting with massive splenomegaly in patients living in malarial endemic area. It due to an immune response to malarial antigen, parasitic antigen. Is that clear? That much is enough. The rest you are supposed to read. Okay, so malaria presents in two ways with massive splenomegaly. One is chronic malaria. Here it is less. In tropical splenomegaly also is rare here, and in India is more in African countries, endemic malarial areas. Children walk around, young adults walk around with large spleen, nothing else. And they have found this is actually a response to malarial antigen. Okay, now the third differential is myelofibrosis. Okay, who will, yes, Prasanna? Myelofibrosis, how will you diagnose clinically? So what we are discussing is differential diagnosis of massive splenomegaly. If you get in the clinical side, we said first I will consider chronic phase of CML, then I will consider malaria, chronic malaria, and of course before going to myelofibrosis, we'll take Kala Azar, because more chronic Kala Azar, yes. Prasanna, you can. Only words, no sentences, points. I will look for the following points. Okay, I will tell you the answer. 3 P's, P, okay? Pyrexia, that irregular fever, P, pyrexia. Pallor, pigmentation, another P. And palpable massive splenomegaly, okay? So I'm making up the 4th P because S won't fit in. So palpable massive splenomegaly. Now can you say all the 4 without looking, Bhakya? Without looking into the book?
Pyrexia, pallor, palpable splenomegaly.
No, you missed one.
Massive splenomegaly.
No, pyrexia, pallor,
Pigmentation.
pigmentation. Where is the pigmentation? Perioral, facial, or generalized. So you have to note it down. Perioral, facial, all of the face, or can be generalized pigmentation. So they are usually patients from commonly from Bihar, Orissa. They are anemic. When you examine, they are, so that's why pallor. They give history of irregular fever, no particular remittent or intermittent fever like malaria. It is irregular fever. Pigmentation, if they are fair, you can make out the pigmentation. And the spleen, of course, is massive. Is that clear? I'm talking only clinical. So you look for this. So splenomegaly with pallor and pyrexia pigmentation, think of Kala-Azar in a particular residence or resident in a particular area or travel exposure. Is that clear? Now, myelofibrosis. Anish, can you discuss myelofibrosis? How will you clinically? What is myelofibrosis? Comes under which group of disorders? You may not have seen a patient. Have you seen a patient? Bhakian, have you seen a patient?
No, sir.
It is, we have had patients here, but I think it's not that common. And CMC, like Vellore, you would see in hematology, you will see those patients. Okay, now Anish, back to Anish. Myelofibrosis, what? Spleen plus what particular findings in the history or findings, which will help you to diagnose?
Fractures, frequent fractures.
No,
Pathological.
actually pigmentation, remember, only for Kala-Azar. Kala means what? Kala-Azar. Kala means
Black.
Hindi.
Black.
It is Hindi, you know.
Black.
Kala means
Black.
black. That is the pigmentation. That's why the name itself, people have given the name Kala-Azar. I don't know the meaning of Azar, but Kala is black. So remember, Kala-Azar is the, or actually there it's called Kala-Azar, you know. Kala-Azar is a pigmentation. Now we are talking about myelofibrosis. What will be the blood condition? Myelofibrosis means the bone marrow has become gradually fully fibrosed. So what will the patient look like, Anish?
Anemic.
Yeah, speaker.
Anemic.
A little louder.
Patient looks pallor. Anemic.
Pallor, severe pallor, because the marrow is fully fibrosed. That is the important. And then what else? Fully severe pallor, massive splenomegaly is the only finding in. And history-wise, chronic history. It doesn't come suddenly. So long history of tiredness, fatigability, because marrow is getting replaced by fibrous tissue. And consultant is asking you, please do a bone marrow study, because patient is anemic. The other cell lines also may be decreased, presenting like pancytopenia. So when you go and do a marrow, what can happen, Bhakya?
Dry tap.
Chips of bones, easily friable bone.
No, bone there
Dry
is
tap.
nothing.
Marrow.
Dry
marrow.
tap.
Right?
Dry tap.
You are doing many things, many times, but you don't get a tap. No marrow is coming. Dry tap. Bone marrow biopsy to be done showing fibrosis. Okay. So what is the clinical finding? Only one finding. Other than splenomegaly, severe anemia. Chronic severe anemia with massive splenomegaly is suggestive of chronic myelofibrosis. If you take the blood picture, what is the clue to myelofibrosis? Prasanna?
Pancytopenia with a decreased
Yeah.
retic count.
Yes, there won't be any retic formation. Okay, I will tell you one point. Teardrop cells. Okay, the common condition you get teardrop cell. What is that condition called? Anisocytosis. Where teardrop is easy to remember because the patient also will have teardrops because of the chronicity of the problem. That's one way to remember. So if you get a blood picture with lot of anisocytosis and many RBCs are teardrops, that's a bad disease to have because only transplant. Of course, you can try some of these immunotherapy and antibodies, and then transplant. We are not discussing treatment now. But I'm saying, so in a patient with a massive splenomegaly can have anemia or polycythemia. You understand? So you have to look at the patient and see what is his hemoglobin like clinically. Is it normal? It can be a chronic phase of CML. If it's anemic, it can be a blast crisis phase of CML or myelofibrosis or Kala-Azar or chronic malaria producing. Can it produce anemia? Bhakya, chronic malaria?
Yes, sir. Because of a prodromic trophocytes, RBC will have the trophocytes. Malarial
No,
parasite will be reside.
no. The good answer should be like this. Chronic malaria with a massive splenomegaly will produce hypersplenism characterized by anemia thrombocyte. You know the word hypersplenism? That is how you get. Any spleen of big size can produce hypersplenism. One more question. Myelofibrosis. Prasanna, why is that spleen is in law? The problem is not in the spleen. It is the marrow.
Compensatory
Yeah. You should
mechanism
not.
to increase that.
Yeah. What is the other rule of answering is don't stop
Stop.
for any response from the examiner. Keep on saying till the examiner says stop, stop, stop. But do you have enough to say is a question, don't say a word and then stop your answer. What did Prasanna say? What was the word you said first?
Compensatory mechanism.
Yeah, you stopped after compensatory. So that should not be. Any answer is a good chance for you to, in the ward, when you are with consultant, the exam is a reproduction of that. Practice the way of saying the full. I will tell you the answer and see why splenomegaly in myelofibrosis. It is due to extramedullary hemopoiesis in organs like spleen. Is that clear? That is what you have to say. When marrow fails, God has provided some extramedullary size, and one such is spleen. That's why the spleen is becoming bigger. As the marrow gets fibrosed and fibrosed, the spleen is getting bigger and bigger. Okay. So pure pallor, splenomegaly, teardrop cells, dry tap, myelofibrosis. Is that clear? 4 points. Chronic, severe anemia, massive splenomegaly, teardrop cell in peripheral smear, dry tap and bone marrow, histopathology, fibrosis. Is that clear? Fine. Now the next condition with splenomegaly. What's the next condition you have written?
Polycythemia vera.
Vera. what is the clue? Okay, polycythemia.
All
How
cell
will you
lines are
diagnose?
increased.
Pardon?
All cell lines are increased.
No,
Patients
clinical.
will
We are
have,
talking about clinical. Clinical. What will the
patients,
patient look like? You have a big spleen, there is no difficulty. Everybody can get the spleen. And the case, the discussion is only a differential diagnosis. That's what we are doing now. Each patient will have something other than the spleen. Other than the spleen, what will be there in the patient?
hematocrit will be more, and patients
No,
are
clinical.
dehydrated.
Clinical.
Clinically, there is an unexplained cause for hypoxia.
No, clinically, what finding? No anemia, number one. So patient will look. How will the patient look? Polycythemia vera? Yes.
Dehydrated.
No, need not be dehydrated. When the RBCs are more, what will happen to the color?
Bright red in color.
Yeah, increase the redness actually, isn't it? That's what a polycythemic look. That is, if you look at the eyelids, you retract and look at it, it looks congested because RBC's mass has increased. And in myelofibrosis, it will be the opposite. Severe anemia. Here, the opposite of anemia, polycythemia. So your attempt is when you get a splenomegaly, assess clinically how the hemoglobin is. Normal hemoglobin, hypo, anemic, or hyper. You cannot assess the hematocrit so accurately, but you can have some guess in that. Is that clear? Polycythemia may have hypertension, but that is not constant. But this suffused polycythemic look instead of the very anemic look of myelofibrosis and the splenomegaly. Okay, now portal hypertension. Anish, how will you look for portal hypertension in a patient with splenomegaly? You want to know whether this is part of portal hypertension. What is the common cause of portal hypertension?
Liver cirrhosis. Alcoholic.
Yeah, you must say
liver cirrhosis.
Chronic cirrhosis of the liver.
Liver.
That's how we must tell it. Okay. And now, how do you classify portal hypertension, Paki?
Post-sinusoidal.
Whether it has whether it resulted in development of complications like
Post-sinusoidal.
No,
ascites, variceal bleed.
classification.
Pre-sinusoidal, sinusoidal, post-sinusoidal.
Okay. Or pre-sinusoid is too histological, you know. You can say pre-hepatic, hepatic, post-hepatic. In the liver, cirrhosis liver. In the portal vein thrombosis, extrahepatic. And IVC thrombosis or Budd-Chiari, post-hepatic, outside the liver. Pre-hepatic, hepatic, or hepatic or extrahepatic. Okay? Outside. Pre is an example, portal hypertension. Portal venous thrombosis. So it has not entered into the liver. In the liver is a liver disorders like cirrhosis, alcoholic, schistosomiasis. And after the liver, the hepatic veins joining the IVC. Suppose it is above that, the hepatic vein also will be blocked and you will get the IVC block. After the hepatic veins joins, you will get a Budd-Chiari syndrome, either acute or chronic. Is that clear? Now, back to splenomegaly. How will you rule out portal hypertension? That's what I was asking. So you must have a background knowledge about it. Anish, what clinical signs will you look for?
Ascites.
I was telling, what is the rule of answering? Rule of answering is go on
Don't.
saying till I stop you to stop. So only ascites is the only sign. There are
Caput.
3 signs for portal hypertension. So all the 3, then only you must stop. What are the 3 signs of portal hypertension?
Ascites, varicose bleed, splenomegaly.
Ascites, splenomegaly, and
Varicose bleed.
no, bleed need not be there.
Gastropathy.
Abnormal,
Dilated veins.
yes,
Dilated
abnormal dilated veins.
Veins.
3 findings in portal hypertension. Okay, and if the liver disease is the cause, it is hepatic. What do you look for, Prasanna?
Signs
If
of
suppose,
cell failure, like
don't stop. Stop. You have to
signs of
continue.
liver cell failure, like temporal wasting, alopecia, icterus, parotid enlargement, gynecomastia, spider nevi, varices,
Palmar erythema, testicular atrophy.
Deputans contracture, leukonychia. You
white
didn't
nails.
say deputans contracture, leukonychia, testicular atrophy. So you have about 10 causes of 10 findings for this is not there in extrahepatic portal hypertension. Okay, these are not signs of portal hypertension. Why do you look for that? So you have to look at the patient and see head to foot. How is the hair? Then comes the hand, leukonychia, and biliary cirrhosis clubbing. Then you turn the hand, palmar erythema, deputans contracture, then chest, usually above the nipple line, so spider nevi, gynecomastia. Like that you have to come, okay? Testicular atrophy. So these signs have to be looked for. If you find those signs in a patient with splenomegaly, it can be cirrhosis with portal hypertension. So you have to look for 2 more signs in all splenomegaly patients. What are they? Is there ascites? Is there distended veins, abnormal distended veins? Okay, we will finish with the veins today. So you have to look for, in a splenomegaly, you have to look for other evidence of portal hypertension. Second, evidence of liver disease, chronic liver disease and hepatic failure. Is that clear? Now about the veins. Well, what veins are to be Bhakya? Where is the abnormality in the vein? In portal hypertension, where do you look for in the patient?
Over the abdomen, sir.
Over the abdomen is a little too
Over the
wide.
abdomen. Around the umbilicus or the flank regions.
Yeah. So you must say, I will look for distended veins around the umbilicus in the abdominal wall. Okay, number 1. Second is the direction of the flow. The veins, what do you look for? Are they seen? Normally you don't see. Are they visible? Are they dilated? Are they tortuous? You have to write those points. Visible, dilated, tortuous. Tortuous means a long time pressure is high, so the vein cannot say in the normal straight line, it becomes curved to counteract the pressure, It is the result of the portal hypertension. Now, Prasanna, what is the direction of flow change in the veins? Next thing you do is, how is the blood going in the veins above the umbilicus and below the umbilicus? What is the normal flow of blood in the abdominal wall? Usually you don't see. If you ever see what is the direction of the flow of veins are above the umbilicus, below the umbilicus, because their drainage is different. Yes, Prasanna. Normal.
IVC.
No, not IVC, normal. Yours and mine, how is the vein? That's draining. Veins above the umbilicus drain downwards or upwards? Below the umbilicus drain downwards or upwards?
Upward.
Everything is upwards?
Upwards. Upwards.
No, that is IVC. That's not correct. So the answer, I will say, normally the veins above the umbilicus empties or flows upwards, ending in the superior venae cava system. Azygos, semi-azygos goes into SVC. Veins below the umbilicus goes into epigastric, iliac, then in back, finally into IVC system. Okay? Normal, taking everything in. So is that clear? Can you repeat it, Prasanna, what I said? Normal flow of blood in the veins in the abdomen.
Veins in the umbilicus, above the level of umbilicus, flow upwards, ending in SVC. And veins below the umbilicus flows downwards, ending up in IVC.
Yeah. Even if you don't say where it ends, you say flow upwards, downwards. Okay? An umbilicus. Okay. Now, Anish, what happens in portal hypertension? The flow, direction of the flow. You have to use the speaker. Yeah. Little louder. Yeah.
Post-sinusoidal.
No, first of all, you will say, you can continue. You can continue. You are following my rule saying don't stop till I say. So that's a good thing. Yeah. Can you start again and continue? The speaker.
If it is post sinusoidal IVC obstruction.
No, so I will tell the answer. Okay. As it is late today, we'll pick it up next week. Think about it. No change in the direction of flow in cirrhosis liver or with portal hypertension. The same. Because it doesn't change. Only thing, veins are big because of the pressure. So it is the normal direction. Is that clear? Portal hypertension, example, cirrhosis liver, the flow of the blood is in the same as normal. Now back here. In IVC obstruction, what's the direction?
Flow will be down to upward.
No,
Upward.
the flow will be towards up or down. There will be veins
Towards umbilicus.
No. I will tell you the answer, you have to work it out. In IVC obstruction can be at various levels, whatever it is. When you may get veins, usually not so much around the umbilicus, in the lateral side of the abdomen and in the back, IVC, and below the umbilicus you can get. When the IVC is obstructed, what will happen to the flow of the blood in the distended veins is the question. Okay. Is it upwards or downwards, or upwards and downwards? That is what happens normal and portal hepatic. You have to work it out. IVC is blocked. Okay.
Downwards and then upwards.
Upward.
No. IVC is blocked, so all the veins you see in the abdomen, even if it goes downwards, it will find a block in the flow because IVC, it has to get in IVC, you know. So all the veins will be going upwards because they are reversing the flow. It has to end in the SVC, superior vena cava system, because the IVC is blocked. So how can it go downwards? It will start going downwards first, but it cannot go because blood will come backwards. And then, because veins do not have, like arteries, the problem, veins have a few valves, but still it can, with increased pressure, it can reverse the flow. Is that clear? So, the veins are very confusing usually. So we will stop here. And I think the other half of the list we will continue in the next